our October Lunch and Learn today. As we think of October, we see pink coming around. Bree's in her pink. I failed. I'm not in my pink today. Dr. Wilcinot is, but she will be talking about some very important topics today. So without further ado, Dr. Wilcinot. Yay.
There's a lot of estrogen in here today. I don't like talking in front of people, so if I talk too fast, raise your hand and tell me to slow down. I also don't talk very loud, so I'll try to keep this up. But they asked me to do this talk. I hate pink. I've gotten a lot of pink in my life the past few years, so I tried to make this not pink, it's black. You see that? I made a black with some blue words. Probably most of you know, but I was diagnosed a couple years ago with breast cancer, so now they think I'm an expert. I don't know that I am, but I maybe have different perspectives all over the place with it now. So I try to keep this also simple and short, so there's room for questions, and I haven't eaten yet either, so if I steal your cookies in the front row while I talk. And do I just push the arrow button to do this? Yes. Okay, thank you. I screwed up. So anyway, all things breast, because I think, to me, breast cancer is a boring topic, which probably is terrible for me to say. So I wanted to kind of make this sort of the journey of, shortly, why do we do it? What are we watching for? What happens next? And so it's a little choppy maybe, but you guys can answer. Anytime you have a question, just ask. You can interrupt. This is not all that fluid. And try to keep it a little light sometimes. But breast cancer, you will hear from people maybe saying that 1 in 8 women will be diagnosed with breast cancer in their lifetime. When I was diagnosed, I was told by somebody, they said, well, I've got 7 friends without breast cancer, they're all female, it means I'm going to get it. Which at the time wasn't that funny, but the median age at diagnosis is 63, so that basically means half the people diagnosed are under age 63, half the women diagnosed are over age 63. So, and it is the most common cancer diagnosed in women in the United States. I actually think that's worldwide, but my stats that I was looking at said the U.S., and it's basically a third. There is a lot more coming in younger people they're finding over the last 5 years, so you'll see that some of the recommendations have changed just a little bit. But there is a lot of advancement. I mean, there is more out there for breast cancer, I think, than any other cancer, which is awesome for people that get it. A lot of money gets poured into research, so there's been a lot of advancements that have really decreased the death rate. They said by 44% between 1989 and 2022. That's a lot. They are catching it earlier, which obviously helps, but there's also different treatments, and they have found different things on the cells that they can target so that the cancer can be better killed, not just, kill the person with chemo, but actually kill the tumor. There's a lot of risk factors for breast cancer. I did not list all of them. The ones that you'll hear about, of course, is the genes. One on the bottom, the BRCA, we call it BRCA1 and 2. Some people have the gene, most people don't. I believe it is 10 to 15% of women with breast cancer actually have a gene. So most breast cancer is not gene related that we know of. But increasing your risk would be drinking alcohol too much, smoking, high breast density. There's a lot of talk about that. There's more and more research coming out about dense breasts. To me, it's just a really nice way to say you're flat. You can have a decent breast size and have high breast density, but in my experience, it's really the people that are A's, double A's. It's called the Itty Bitty Titty Committee. I was a member. Older age at childbirth, people don't really think about this very much, but there are calculators out there where you can kind of calculate what would be my average risk of getting breast cancer. They always include how old were you at your first childbirth, but also how young were you when you first had your period. There's a lot to go into that. The estrogen is floating around earlier. And I'll bring up a little bit later on about some of the risk calculators. They don't, this is bad advice, but they don't mean a lot. I did my risk. My risk was 0.8% compared to the general population of 0.6%. I had bad luck. So, and I don't mean to make this all about me, but it's easier to talk about it, I guess. So screening, mammograms. It's an annoying word. People in general don't like them. But I've talked with my patients, probably some of you out there, they would come up with something different. If you had to squeeze testicles in between two plates, they'd come up with a different way, right? Well, we just put up with it, and we just use the plates to this day, so I thought that was kind of fun. But the mammogram is still the gold standard for screening average risk women. There are women out there with higher risk, which we'll talk about a little bit. There are other ways to screen, but those screening tests are typically not covered by insurance. Even when you are high risk, it's sometimes hard to get covered, so it's kind of a touchy subject. I have talked with patients in the room that, hey, you are higher risk. We should probably be ordering these other tests on you. We've done a few, and sometimes they come back a little angry because it hasn't been covered. So it's a little bit of a game that way, but there is a high-risk breast clinic in Sioux Falls attached to the Prairie Breast Center. So if I do find people, if you know of yourself that you have the gene or something, there is a high-risk clinic that helps to deal with all those issues. So the top here, there's three things. ACOG on the top right, it's the OB-GYN people. It's like their it's like their God that they listen to. The middle is the American Cancer Society, the ACS. And then the left is the United States Preventive Services Task Force. That's another group that gets together. The family med docs, we tend to obey those recommendations. So there's lots of different groups out there that you can listen to. So if you hear one doctor say, I recommend this, but the next doctor says, but I recommend that, it's probably because we're obeying different groups of people. So the age to start under the USP, it did say 50 up until I actually had made this, and then I found new research. This was first 2018 was this chart where I put the asterisks. It actually was just updated. I did not know this in 2024. So the USP used to say start at age 50. They did not say 40, and they said every other year, and you stop typically after age 74. Now that is for average risk women. So if your mother has breast cancer, let's say you're not an average risk woman. But they did change it. That's one of the new recommendations now because breast cancer is more and more in young women. So they did change theirs to age 40. Then the American Cancer Society still says, from what I could see, age 45, but you may start at age 40. They're not against it. You know, you talk with your doctor about it. They like it yearly when you're younger, from age 45 to 54, then every 1 to 2 years, depending upon what you and the patient decide. Their age to stop, that has also been a little murky. Even when you come into my office and the Avera, we have a little thing on the wall, what Avera recommends, they actually have their breast cancer screening going up to age 85. Because they kind of have taken this and said, well, people are living longer. So it's really up to the patient. I know all of these say age to stop, 75, discuss it. Typically it is when life expectancy is less than 10 years. Do you want to continue doing mammograms? I tell my patients, you probably heard this from me, if you're 80 years old and you're really healthy, you can surely get a mammogram. You kind of have to ask yourself if you would have cancer. If they would tell you next week that you have cancer, would you want to treat it? A lot of people would, and that's great. But some people, if you have other health problems, they might say, no, or I saw my sister go through that and no way. So it is definitely more of a decision after age 75. You just have to kind of weigh who you are. Yes, and then ACOG, that last one, the OB-GYN people, they were kind of wishy-washy. Now they also say at age 40. And I thought this was just too good to not put in here. My kids actually were watching me do this, put this together, and my son, Mom, why is that? So I had to explain to the poor, and actually my daughter too, of course, she has no idea. So higher risk women are kind of a different bird, and I don't know that we do a very good job catching high risk women. So you are more than average risk if you have very dense breasts. Now that's kind of hard to know. A lot of people, the mammogram will say dense breasts noted. Well, that's a lot of us. They are starting, there is a scoring system now that Avera just started not too long ago that is now on your mammogram. It gives you a Tyrer-Cusick, it's a TC score, and part of that score does incorporate the density of your breasts. So we're getting better at catching this. Of course, if you have one of the genes, the BRCA1 or 2, there are some other less known genes, but if you know that you have the gene or your mom had the gene, greater than 20% lifetime risk, that is what that score is on your mammogram sheet. So if you guys, when you get your mammograms now, kind of pay attention, it's about 2/3 of the way down. I was actually gonna put one up here and then I totally forgot. But the average risk is about 12 to 15%. If you're greater than 20, it's worth a discussion with the doctor. Do I need to screen a little differently or not? And then I didn't put this on here, but just family history. If first degree family history, so if you have a daughter, a mother, or a sister with breast cancer, you are higher risk. Then what they can do, and again, this isn't done all that often, we're trying to catch more people that are high risk, is not just a mammogram. When you are part of the committee, you can't even get it into the mammogram machine. I mean, it doesn't happen. So maybe more information than you want to know, but when I had an enormous tumor, they couldn't get it on the mammogram. They biopsied it, they tagged it with the cute little clips that you all get, and then they have to mammogram it again. They couldn't find it. It was there, you could pretty much see it across the room, but they couldn't get it in the mammogram machine. So my mammograms were completely normal with an inch tumor in there. So that is why if you have dense breasts, it is not a good test, and I'm not supposed to say that. But mammograms are not perfect, and that's where these come into play. That up there is a picture of an MRI where you literally lay on your stomach and just let them dangle. And you lay there with headphones on. Yes?
So, if you are high risk, really mammograms aren't,
They still recommend them.
they do.
They
but
still recommend them. So I would never tell someone, don't get a mammogram. But let's pretend you feel a mass. You go do a mammogram and they don't see anything. Somebody along there should catch, whether it's the radiologist reading it, sometimes there's an ultrasound done. There needs to be something more than just a mammogram if you feel a mass and there's nothing seen on the mammogram. Especially if they say very high dense breast.
So did you feel a mass then?
You see it across the room literally.
Okay.
I didn't ignore it. I was told it was normal a couple years prior. And I trusted my doctor because I want you all to trust me. And I don't blame them, but it was there and I thought it was scar tissue. I had, from nursing, everybody gets mastitis. I had mastitis in the same spot, which to this day makes me wonder, did I have mastitis because I actually had tumor cells in there? That was when I was 35 years old. So I went in at 37 and they told me it was normal and I believed them, I really did. Then it just kept growing. One of my friend is not here. One of the mammogram techs said, dude, what are you doing? You need to go in. Fine. Turned 40, went in, and my mom always said turning 40 is the shits. It really was. But, so we don't want everyone to go rushing, trying to get an MRI or this other thing called a CESM, Contrast Enhanced Spectral Mammography. Lots of work. CESM is basically it's contrast. And this picture here is a little bit confusing, but when you put contrast, this is like a snowstorm, but somehow they do it in phases where like, hey, that looks abnormal. If you had this entire thing, you're like, I don't know. So they are better than mammograms, the CESMs, but the MRI is where they think that's probably the best if you have very dense breasts or you're very high risk. More about me, I'm sorry, but they had told me because of how dense, and I wasn't high risk otherwise. I don't have anyone in my family first degree that has anything. don't have genes, I would exercise, I'm fairly thin. But because I was so high risk, they said if I had kept them, I would have had to get an MRI every single year of my life. It's not worth that to me, but, so it is, it's something that we should be talking a little bit more about, and it's not always just dense breast, it can be, well, yeah, my sister had it, my mom had it. Also, there's maybe a slide on here about if your dad had it, a brother, men can get breast cancer, and I think we kind of forget that is actually quite high risk. 40% of men that have breast cancer actually have the gene, when only 10 to 15% of women do. So if you have a dad that had breast cancer or an uncle that had breast cancer, that's more likely you could have the gene running in your family. So, enough about that, I suppose. And then we don't talk enough about self-breast exams. So really, like, getting back to the men and also very dense-breasted women, we don't do a very good job of probably telling you, make sure you do your self-breast exams, and I kind of always thought, whatever. But really, you know your breast more than anybody. I tell my patients too, I can go feel any woman's breasts in the clinic, and I can pretty much, you can almost find a mass, and that's maybe simplified and stupid, but they're all lumpy and bumpy, and you all know that. So the best is for you just to do it. They say, if you're still having periods, do it same time of the month. Basically just do it when you remember. It's still one of the best things to do, especially when you kind of talk about high density versus not. So let's say you had a mammogram and we call you, this happens all the time, because they do overread mammograms. I mean, it looks like a snowstorm, and if they don't have a lot to compare to, they want to make sure, what is this? So you get called fairly often. What you're typically going to have is a diagnostic mammogram, which is pretty much the same thing that we do here in Sibley, but we can't do it in Sibley because they have to have the big bad docs over there. So you do pretty much the same thing except a few more views, squeezing you a few more ways. Then very likely you'll have an ultrasound, just like a baby ultrasound, they just do it to the breast. Then based on that, they will sometimes say, well, we did find something, it looks suspicious, let's do a biopsy. Sometimes they'll say, oh, that actually was nothing, a fold in the skin. I literally had that recently. Sometimes, oh yeah, it's just a cyst. So if we call you for more imaging, don't freak out, I guess is what I want to say. It happens a lot. It's just the pathway that we go down, and actually having had a diagnostic mammogram and then an ultrasound in your chart, let's say 3 years down the road, there's another mammogram that looks a little bit different, they can pull up those old images and say, oh no, it's actually just like it was back then. So it's a nice comparison. We like to try, and we apologize for this, sometimes when you have to go to Sioux Falls, it's not all set up, and then you have to go back again, and we feel really bad from the clinic side because they're trying to call us saying, can we have an order to do the biopsy? When am I going to say no? But they have to have the order. So sometimes you guys are sent home and then have to go back, so we apologize for that, but hopefully we can get it all in one fell swoop over in Sioux Falls. But if you ever have to have a biopsy, it actually does look something like this. They call it a core needle biopsy. It's a fairly large needle. Of course, they numb you up. They use this ultrasound and they kind of find, okay, here's the breast lump. And then they go and they get a piece of it. And actually, most women, I don't think it's that bad. Might sound worse than it is. So let's say you had a biopsy done and they tell you it's cancer. So there are different types of breast cancer. That top one, DCIS, is the IS means in situ. It's not full-blown invasive cancer. I kind of would equate it to, if you get a skin cancer, you can have a pre-skin cancer or a true. The DCIS is kind of like a pre-breast cancer. They still would want to get rid of it, but typically you don't need extra treatment, you don't need chemo, radiation, all that. The most common type of breast cancer is what the picture is, invasive ductal. So we have ducts, lobes and lobules that make the milk, then you have the ducts. Most of the cancer starts in the ducts. And so here's a pretty one, normal, and this one is not pretty. And if you imagine, so I'd like to do a study on this. Women with mastitis, is it just milk plugging? Is something else plugging it? Just interesting. So invasive lobular starts here in the lobules, the lobes. Invasive ductal starts here, and this is the most common, the ductal. The inflammatory breast cancer is pretty rare. I've had just a couple patients with that I know of. And then Paget's disease of the breast, almost think of it like a skin condition, but it's truly breast cancer. I think I have a picture. So this was a whole different thing at home. When my kids saw this, I had to be like, oh my goodness, get out of here. Like, get out. Oh, sorry. So Paget's disease of the breast, if you ever have around the nipple, like eczema, like a itchy, scratchy, that is something that we usually want to look at. You know, sometimes we'll say, well, for a week, put a cream on it. If it goes away, we're good. If it doesn't go away, it can be Paget's disease. That left-sided picture, it can look like eczema. It can just look like, you know, people get fungal rashes in their creases. It can look like that, and that can be breast cancer. The one on the right is even really, it's actually hard to see in here. It looks almost like a mild sunburn. It's just very, very mild, and it doesn't want to go away. Sometimes we biopsy those, and it'll show breast cancer, actually. They say it's cancer in the lymphatics, which are little tiny vessels, and the cancer cells plug it up, and then it looks red. So, more rare, but it does happen. So let's say you had your biopsy, you're told it was cancer. They test every biopsy tissue that's positive for cancer for these 3 markers: estrogen, progesterone, and HER2. That is where breast cancer has really gotten better over the past 10, 15 years. They figured out most tumor cells will have one of these 3 on it, and you can go after it and target that cell by what's on the outside of the cell and kill it. So in other words, mine was estrogen and progesterone positive. So what do? They try to take every little shred of estrogen and progesterone from you, and that's like the food for the tumor cell. So you're not feeding, if there's any cancer left in me, I'm hopefully not feeding it any food. Same with HER2. HER2 stands for Human Epithelial Growth Factor Receptor 2. You can have triple negative cancer, so there's none of them on the cancer cell. You can have triple positive, where all of it is. They have specific drugs to target HER2 nowadays, which is awesome. So you don't just get chemo and radiation, you can also have the immunotherapy. Same, you've heard of tamoxifen, probably some of your friends. Tamoxifen is one of them for the estrogen and progesterone. So that's probably the biggest advancement in breast cancer in a while, and it's a very good positive thing. Your biopsy result might mention lymph node involvement as well. It might say, you know, invasive ductal carcinoma, lymph node found positive, or no lymph node involvement found. But that's also just where they're shooting, right? So wherever the needle went, if you shot up here, but you had a lymph node over here, you'll miss it. But the biopsy result, when we call you and say, it's positive for this type of cancer, you're probably also going to hear from us. In a day or 2, you're going to get more results. These are those results to tell you. This has a lot to do with how you're going to be treated and your prognosis. Triple negative might be a little worse prognosis because you don't have anything necessarily to target. I kind of consider that like the old cancer way, where you just do your best you can with the chemo and hope it helps. And then staging, everyone always asks me, what stage were you? It's actually a very difficult question because staging really changed in 2018. They used to do just 3 things: the size of the tumor, whether you have nodes positive or not, and whether you have metastasis, whether it's outside. Now, it also, I believe, used to be metastasis would actually include if you have positive nodes, you were stage 4. That's scary because a lot of us have positive nodes. That's not the case. So breast cancer metastasis is actually outside of the nodes and the breast. You have to be liver, lung, something like that. 2018, they also then involved those receptors, estrogen, progesterone, and HER2. So, you know, let's say you have a tumor size of 2 centimeters, no nodes positive, no metastasis, like a stage 1, and with your ER, PR, HER2, if you're positive in those, it downgrades you to something better. So it's all changed, and they will even stage before treatment versus after treatment. And really, to me, they never came out and said, you have stage blah, blah. So they do that behind the scenes, the docs do a lot, the oncologists, based on, this is what she is now, but we're gonna give her treatment first before surgery. It gets confusing. So if you ask someone which is your stage of breast cancer, it's a little more involved than what it used to be. For treatment, I can't speak for anybody else, but the Prairie Center did such an amazing job of everything, explaining things. She broke it down. The breast surgeon, who you always see first. Let's say you get breast cancer, you're going to see the breast surgeon first, whether or not you even have surgery. Let's say they have to break it down to 2 things. You got to treat the breast. You got to treat the body. The breast is typically surgery. There are some women who say no. It's your right to say that. But typically it's going to be a lumpectomy versus a mastectomy. You can have a one-side mastectomy, you can have a whole thing. And some of us, if you did a lumpectomy, there's nothing left. So just do the mastectomy. So they break that down, but then the body is chemotherapy, radiation. Now, not everybody needs any of that. I've had some patients, they have their little lumpectomy, they're done. Maybe they just have, I shouldn't say done. Part of the chemotherapy is also the immunotherapy, the anti-estrogen, the anti-progesterone. And while that's chemo, I think it's not seen as, you know, you take it every day and just like it's your aspirin. Maybe get a few hot flashes. But that's where the treatment has really changed the most. Chemotherapy, they break that down also according to how many lymph nodes you have positive. If you have no lymph nodes, a lot of people don't need chemotherapy anymore. So things have really changed, and for the better. The very bottom there, neoadjuvant treatment, very big word. Some people will have chemo or radiation before surgery at all to shrink the tumor, and it changes your stage completely. So that's where I've had I had surgery first. A lot of women have chemo and radiation first, and they go from a tumor the size of a, you know, small orange to almost nothing. It's amazing what it can do. So it's not cookbook medicine, it's very, very tailored to you. This is actually, this is the radiation, one of the rooms at the Prairie Breast Center. It's kind of hard to see. It's very pretty. They lay you on here, if you can see this, that is like it was like a bean bag. If you've ever had a fracture and the EMS people come around you and put a bean bag and they suck the air out and it kind of molds to you, that's what that is. They have you lay in a bean bag, they suck and put you in a perfect position, they suck the air out and they label it and that's yours. And they have a little cupboard and they put it in the cupboard and every time you come for radiation they get you out, lay you there. And they strap you down, your knees go here, you lay there. These things rotate. So it's like you get used to where they're at what time, and one day I broke it. They had to call their nuclear physicist while I laid there with my arm up for 45 minutes. But I think people are scared of radiation, and I can't speak for everybody, but I thought radiation, I told my boss, it's like it was a vacation. Worked till noon every day, got to leave. This literally takes 15 minutes. By the time you maybe change and you talk to the ladies, maybe a half an hour. It is really hard on some people, but it's different for everybody. Breast radiation, I think that skin is a little bit tougher than some other parts of the skin. I got home earlier every day that summer, so I thought it was pretty great. And I couldn't. This is for you, Glenn. I thought that was just pretty good. Yeah, a lot of facets to breast cancer, but I had my kids shave my hair because I thought it'd be a little freaky if I came home bald one day. So they shaved me, and my daughter, I looked about just like that, minus the chest. And my daughter looked at me, "You look like a turtle, Mom." And it kind of does. It kind of does. So, prognosis is also a little bit kind of a moving target. Prognosis is obviously based on how bad do you have it, which would be the size, the lymph node, the stage. Typically, the higher the stage, the worse the prognosis. But things have improved so much. The best numbers that I could find, because it depends on what you read, they'll have 5-year survival, they'll have lifetime survival, and whenever they do survival in cancer, it also includes other things. So if the cancer is diagnosed at an older age, well, older people have COPD, they might have heart failure, so they are going to have a less good 5-year survival. So these are about as best I could find, but if you have localized, which is stage 0 to 1, 99% 5-year survival. That's, can't get better than that. It's basically normal. Stage 1 to 3, and the way, so the stage 1s overlap because of that estrogen, progesterone, HER2 receptors. If you're triple negative, you might be a lower stage 1, closer to stage 2. 86%, it's stage 4 in any cancer. Stage 4 is when it's outside the organ. And with breast, outside the breast and outside of the lymph nodes, so liver, lung, brain. Obviously that survival is not nearly as good. So the whole trick is to try to catch it early, just like any other cancer. And then I just have the one slide on breast cancer in men. We kind of talked a little bit about it, but less than 1% of breast cancer is diagnosed in men, which makes sense because I don't know anyone personally that has had breast cancer as a man. I have heard of someone. That's about it. So when I found 1 in 1,000 men will get it, I thought that seems like too much. I think that'd be a bigger number. But if you do have the BRCA gene, their lifetime risk is much more. 50 in 1,000 men will get it. Because we have to remember, not just women have the gene, the men can have the gene too. And men, some of the stuff that I looked up actually did recommend men getting mammogram if they're high risk, but then how does that work? I mean, they're dense by definition. But all the things that I read basically said men should just be doing self-breast exams and clinically in the clinic as well with their doc. So if you know of a man that has breast cancer or had breast cancer, their family needs to take it a little more seriously too, because much more linked to genetics. And there's some boring references. I thought this was really good. We flash them, we smash them, we push them way up, if you got them. We shake them, we stuff them in the wrong sized cup. Our husbands just crave them. Our children have drained them. Some of us even decided to name them. We go through our lives and knock them about, but one thing is certain, one thing I must shout. Our boobies have been there through thick and through thin, and life is too precious to let cancer win. So, picture is quite great too. So any questions? Yes, way back there.
Does any other type of cancer and family history change that risk, other than breast cancer in immediate family?
So BRCA, BRCA1 and 2 also carries like pancreatic and prostate. So, we don't tell our patients, oh, if your dad had prostate cancer, you should be getting more mammograms. But there are links to genetics. So if you had a prostate cancer that was linked to the BRCA gene, yes. BRCA positive patients should actually not just be getting breast cancer screening more. Sometimes they get pancreatic screening. So it's a little bit woven, and they're finding more and more genes all the time. When you go to the genetic counselor and you get your genes done, and they say, well, you might need to check up with us in 5 years because we might know better genes by then. So then they look you up again and say, oh, you have a gene that we didn't know was bad, and it is. So I didn't touch too much on the gene thing, but Avera is trying to send everybody with breast cancer to the geneticist, everybody across the board, so you can have a discussion.
They said to me that genetics was very important, but very few women do it because they either don't wanna, look into it, but my kids wanted to know.
Mm-hmm.
And they said, when you just take a lump, it goes faster. I mean, there's more studies.
Mm-hmm.
And when you just have both of them taken, they don't do many studies. So they got not really anything to go on and how to tell you what to do.
So when I went to the geneticist, they offered me four choices. The fourth choice was do nothing, don't test at all. I could have just had the breast, the BRCAs, and there's a couple other, just those tested as a yes or a no. Then there was the second package that was, well, like the other cancer ones too, maybe the ones that are more prone for lung or whatever. And then the third one was, we're testing you genetically. We are probably going to find something, whether it's MS, whether it's some other, who knows, dementia gene. I don't know. They offered all of them, and I said, well, what's the price? Well, it all costs the same. So I'm a Dutchman, and I got it all. And they warn you, well, they actually tried to convince me not to, because they were saying, well, if you do it all, you're going to find something, you're going to go crazy. I'm like, I don't go crazy. I'm pretty laid back. I'm fine. Okay. So I did it all. It's all fine. I have a fair amount of women that go and choose to do nothing, and that's okay, but I think that's always a discussion with the family, because I think you getting tested is just as much for your family members as it is probably for you. And I think maybe I'm not sure my patients take their family along with them for that discussion enough. People, I think, are really scared to get tested. I think it's a good thing, even for research purposes, honestly, because they will, not using your name, and they'll ask you, but they can use your information in their research stuff just to get better at it, to figure out, oh, this gene actually could be linked to that. So, and Avera, I go to some weird cancer meetings, and they're really trying across the board, not just with breast. It's breast, pancreatic, and one more, I can't remember, but they typically will send everybody to the genetic counselor. They want to get to every single cancer gets sent. And as of right now, they're not, but they want to. They have the capacity, apparently, to do that. They have more and more genetic counselors there. So, and if you ever, this is sort of off, but if you ever need genetic counseling for something that's not cancer, you're still going to get sent to the cancer building, so don't freak out about that either. They're all in that building. So, yeah.
Well, my husband has pancreatic cancer, and they just pestered the life out of him to have that genetic counseling done.
Mm-hmm.
And he did, and it came back perfectly fine.
Yeah.
There was so our children would not have any worry about picking up or having that
Yep.
gene or whatever. So we were glad that we did, but it's a scary thing.
It is, and it's, if you find something that you weren't bargaining for,
Yeah.
you have to be able to deal with that and think about that. That's where I think a lot of people don't want to get it done.
One more question.
Yeah.
I've been reading something about a vaccine for cancer. What's that all about?
The only one that I know of, so we have that HPV, it's Gardasil vaccine. We give it to our kids because cervical cancer comes from, like 90-some% of cervical cancer comes from the human papillomavirus. We do have a vaccine against that. And so that has reduced cervical cancer by a lot. I would assume there will be more out there. Maybe this virus causes that cancer. I haven't heard anything, but doesn't mean it's not happening. Good. Yeah.
Do anybody, like, for preventative? What daughter would like to do preventative?
You mean like,
Do the double mastectomy and.
oh,
And do.
if they have the gene, does she have the gene?
Gene.
So right now, as far as I know, insurance will only cover preventative if you have the gene.
She said they will cover her because, well, I've had arthritis.
Hmm.
So
little sisters had it twice. But I've done 2 gene things, one with
Negative.
and one with 75
Yep.
genes.
Yep.
And they're all negative. And they had a third one that you said, it's brain.
Okay.
Brain.
I would never, I mean, if there's that much in the family history, I wouldn't fault
So is that-
anybody.
Well, she has dense breasts, so is that that she can get it done? I'm like, you should be able to do that.
Insurance changes all the time. I think, I mean, it's up to anybody, and I shouldn't make cost be the only deciding factor, but cost runs the world.
She said her insurance, her doctor.
That's good.
Enough of the family history.
It's great. I mean, it's her decision. It's something that obviously you can't predict. And those prediction tools, I feel like they're good and bad. I mean, how dumb frustrating. You do a prediction tool and you're way low, yet you still get it. I don't know, what's the point?
Yeah.
But-
And isn't ovarian linked with breast cancer?
Yes, certain of them are. Which ovarian cancer is a whole different topic, that we're not supposed to screen for ovarian cancer in the average risk patient. High risk patients, though, I've never read any paper or read anything that says high risk women should be getting ultrasounds, let's say, of their ovaries all the time. So ovarian cancer is, I feel like we ignore that way too much. But that is part of, I believe it's BRCA2, I think.
What about the endometrial?
Endometrial cancer?
Yeah, because isn't that caused by the tamoxifen? Sometimes.
Sometimes. One of the things I did not put in here would be, so the risk factor, birth control pills are good and bad. So birth control pills, let's say you start taking birth control in your early 20s. Birth control pills in general can increase your risk of breast cancer, but lower your risk of ovarian and endometrial cancer. And so it's kind of a tough, plus it helps prevent pregnancy, and you know that can be life altering depending upon if you're planning one or not. I mean, people have horrible periods sometimes and then their life is miserable. So the reading that I did on that, it was very, I don't want to say political, but they don't want to say, how dare you take a birth control pill when your mother had breast cancer. They don't want to tell people that, even though it could be increasing your risk a bit. So, and endometrial, it might protect it, they think, and ovarian. So you do one thing, it's good for this, and it's bad for that. It's hard to decide.
Thank you, Dr. Wilcinot.
There you go.
Thank you guys for coming. Our next Lunch and Learn, Dr. Serb will be doing the topic of sleep. We do not have a date set, but keep an eye out. Sleep, yes. Thank you guys. Have a good day.